Hello, everybody. Thank you for joining tonight's webinar presented by the New York chapter of the American College of Physicians. We are very grateful to have Malya, Levin and Meredith Levine from the Weinberg Center for Elder Justice. This is the first part of a two-part series. The next part is March something at 4 o'clock, but I'll tell you that when we get to that slide. Next slide. So for those of you who are not familiar with NYACP, NYACP is the largest medical specialty organization in New York State. It advances the specialty of internal medicine as well as its subspecialties in New York through education, advocacy, and quality improvement. And it represents over 12,000 internal medicine physicians. So here we go. So we have a few upcoming events. March 6th is recent changes to Medicare coding. That's by Bob Zarowitz and joint with MAGS. March 19th, I knew it was in March, is the second part of this series. And then there's several Women in Medicine series. So please, check them out and register if you can. NYACP is excited to announce that the annual meeting is set for October in Tarrytown, New York. I used to think Tarrytown was upstate until I started going to Rochester. And now I realize how big the state is, but that's okay. So Meredith Levine is a senior elder justice specialist at the Weinberg Center. She's an advocate for trauma-informed practice and advanced care planning, got her master's of social work from Columbia. She's a fellow of the Hartford Partnership in Aging Education Program, is board certified in palliative and hospice care. And she's a 2023 graduate of NYU Zelda Foster Leadership Fellowship. And our other speaker is Malya Levin. She's a lawyer and assistant director and general counsel at the Harry and Jeanette Weinberg Center for Elder Abuse. She's a coordinator of Westchester County's Elder Abuse multidisciplinary team. She's also a member of the executive committee of the New York State Bar Association in elder law and is named one of New York Jewish Week's 36 under 30 for 2018. And she graduated from Brooklyn Law School in 2012. My uncle went there. So in terms of disclosure, the planning committee there are no planners or anyone else in control of the content that have any financial relationships. There are no faculty that have any financial relationships with ineligible companies. Seems like it should be self-explanatory, but just to be sure, ACP is opposed to harassment and has an anti-harassment policy. This is the education committee more broadly for the NYACP. For those of you who don't know me, my name is Paula Lester. My family likes Mickey Mouse, as you can see. And I am currently the chair of the geriatrics task force and the governor-elect designee for the Long Island chapter of NYACP. So you can earn 1 credit of CME for this course. We will very briefly show you the QR code, and then towards the end of the presentation, we'll send the link through the chat. And if you're not currently an NYACP or ACP member, then you can open up an account to get your CME. Next slide. I think we are also offering MOC for those of you who need it. So thanks in advance for joining us for this course. There's lots more resources that have been already recorded and future activities, so please check it out at ACP Online and at the NYACP webpage.
Well, thank you, Paula and Isaiah, for arranging everything and for having us here tonight. I'm Meredith Levine. I'm with Malya tonight. We're going to be talking about elder abuse. Malya, do you want to go to the next slide? So we work for the Weinberg Center for Elder Justice at the Hebrew Home at Riverdale. And our primary focus is operating an elder abuse shelter program within the Hebrew Home. But we do other things as well, some of which is educating professionals such as yourself about elder abuse. We coordinate multidisciplinary teams about elder abuse in Westchester County and sit on the Manhattan, Bronx, Queens, and Brooklyn MDTs as well. We also coordinate and lead the Spring Alliance, which is a network of shelters that have replicated our model throughout the country. And we're also involved in policy and advocacy, and we offer consultations to professionals such as yourself about elder abuse and how to handle it. Next slide. Thank you. So the Weinberg Center, as I said, is an elder abuse shelter program, and we're unique because we're located within the Hebrew home at Riverdale, which is a nursing home setting. So clients who come into the Weinberg Center are able to receive all of their medical care from the Hebrew home. And so depending on their needs, they might go to a subacute rehab floor if they have subacute needs. If they have memory care needs, they'd go to memory care floor. If they need skilled nursing support, they'd go to a skilled nursing floor. And they receive rehab, therapeutic activities, whatever they need through the Hebrew home. In addition to that, they also receive Weinberg Center services, which include trauma-informed social work from social workers. So they receive case management, psychotherapy, and they also receive legal services as well from our attorneys. We have 4 attorneys on staff. And we also have a public health professional because we look at elder abuse from a public health lens. All of our clients are originally in the community, and they come into shelter temporarily with us to receive support around their elder abuse. And the goal is always to discharge them back home. And so we coordinate safe discharges for them. Usually it's a pretty complicated discharge because they've also experienced elder abuse. And we also have a transitional care social worker that continues to work with our clients after they've returned to the community, just because we found that people need that added layer of support when they're returning home. Next slide. So what makes someone eligible to come in to the Weinberg Center? They have to be experiencing elder abuse, of course. They have to have no other safe living option. Really, where an older adult comes to when they have no other option in the community. They have to be 60 years or older, and they have to be willing to break contact with a person who's harming them. And we're going to talk in a little bit about why that's so complicated for our clients and for people who've experienced elder abuse in general. And the older adult has to have the capacity to choose to come into shelter, or they have to have a surrogate decision maker. That could be a guardian, that could be a healthcare agent, or that could be a representative under the Family Healthcare Decision Act. There's some things that would make an older adult ineligible. So if they're actively using substances, that's not something that we would be able to accommodate. If their behavior is dangerous to either themselves or other folks, that's something that would also make them ineligible. We have to keep in mind the safety of other residents in the nursing home, as well as our clients and staff. And they have to have a payment source for the nursing home. So we can help people apply for institutional Medicaid, or if they're coming in for short-term rehab, Medicare could pay for their stay. All the Weinberg services are free, but we do need a payment source for the nursing home. But always talk with us. We can help figure a plan out. Our referral number is down below, and it's also on one of the last slides, so don't feel like you need to jot it down right now. Next slide. Okay. So what is elder abuse? We have the CDC definition here, and we really like this definition in part because it highlights something that we see often in our clients, and I'll just read the description. Elder abuse is an intentional act or failure to act by a caregiver or another person in a relationship involving an expectation of trust that causes or creates risk of harm to the older adult. And it's really that phrase, the expectation of trust, that we find rings so true. There's no universal definition of elder abuse, but this one seems to really hone in on what we see. We find that there are several different types of people who cause harm to older adults, and most commonly the person who is causing harm is the person the older adult would trust most, and that's a family member. For older adults, it's often an adult child, and you can imagine how hard that is for an older adult to be experiencing harm from from someone they've raised and someone they've nurtured. We also see that sometimes the people causing harm are partners. So sometimes it's a situation where domestic violence has grown old. It's a partner that the older adult has been with maybe for most of their life, but the abuse has kind of reached an intolerable level or a very dangerous level, in part because of the frailty that the older adult is experiencing due to older age. And we also sometimes see that this person who's expected to be trustworthy is like an opportunistic stranger. So maybe like a home attendant who is taking over the older adult's finances or other resources, or even sometimes it's a stranger who's trying to ingratiate themselves and become a part of the older adult's life in order to target them maybe financially. So I have some statistics on this screen. Elder abuse is very common. 1 in 6 people over the age of 60 experience elder abuse annually worldwide. In the United States, I think the statistics is 1 in 10. So it's happening to your patients very commonly, but it's not often reported. So for every case of elder abuse, 23 more go unreported. And you could probably think of a few reasons for that. And one of them is that the people who are causing harm are the people who are so trusted. And we find that our clients, it's very hard for them to view themselves as victims of elder abuse or victims of any crime when the person who's hurt them is an adult child. And oftentimes, the older adult is thinking of themselves foremost as a parent. And their goal is really to protect their adult child, even if they're causing significant harm. And there's also a lot of shame about being in this situation where your adult child is harming you, or being in a situation where anyone is harming you. And a lot of fear as well, like what's going to happen to the older adult if they do report? What if they've been relying on this person who's hurting them to provide them care? So, that's some of the reasons why it's so unreported. Another statistic that probably does not surprise you is that close to 50% of people with a dementia diagnosis experience some form of abuse. There's not a lot of great research on that. This study that we're quoting from 2009 is was from researchers calling actually caregivers and seeing what they would report. And of course, someone wouldn't be motivated to talk about the abuse they may be committing, but still 50% of caregivers were reporting that they had harmed the person with dementia. And you can imagine it's incredibly difficult for a person with dementia to report the abuse they're experiencing, depending on where they are in the stage of illness. Elder abuse is also very expensive, 28.3 billion annual losses a year. I've been with the Weinberg Center about 5 years, and each year we update the slide and the number gradually increases. And it's very hard to conceptualize like what is $28.3 billion mean? I was trying to figure out in the few minutes before this presentation, like how much would it cost to cure homelessness in the United States? And okay, this is a really difficult thing to figure out. There are different numbers, but one I reliably found was about 20 billion a year to resolve homelessness in the United States. And then of course, medically related, there's recently this amazing grant that Albert Einstein Medical School received for $1 billion to eliminate all student debt. So it's very expensive, and it's hard to really conceptualize what it costs older adults. And we also see that, a person doesn't have to be a millionaire to be financially exploited. Even that small SSI income is really tantalizing to people because they can rely on it. It's a check that's hitting an older adult's account the first of the month that can be used. Next slide. So we have a case study. This is actually a gentleman. It's based on a gentleman who came into shelter with us at the height of COVID. His name is Mr. N. He's 70 years 78 years old. He has diagnoses of type 2 diabetes, hypertension, COPD, and he comes to the emergency room with acute abdominal pain, and it's discovered he has a large abdominal aortic aneurysm. And he has surgery, actually 2 surgeries to resolve this, and he's healing really well. And he tells his surgeon, I cannot go home. She will kill me. I'm like a porcelain doll now. And through talking with him, his medical team figures out some more about his history. So he's originally from Jamaica. He's very engaging, lovely man who has 6 children, most of whom still reside in Jamaica, but he has one daughter who lives with him. Her name is Tara. And Tara is schizophrenic, does not take her medication, and can become very violent, in particular at night. So Mr. N is a robust man, has always been able to take care of himself and provide for his family, and also to provide for Tara and keep her housed. But things have been escalating. And what he does at night is he barricades his door to keep her out, because this seems to be the time when she's most psychotic. He had surgery a few years ago, and it was a pretty simple surgery, and it didn't leave him too infirm. But Tara was able to get into the room and tried to take the sutures apart, when he was asleep. So he's very scared now about returning home, and he's telling his medical team, I cannot go home. She will kill me. He has one really involved daughter, Janet, who is in Jamaica and is aware of the situation and decides to fly back to New York to help her dad navigate the situation. So if you were Mr. N's physician, what would you say to him if he's telling you all this information? It's a lot to hear, and a lot to help him plan to address. Any thoughts? You can put it in the chat if you don't want to unmute yourself.
Hey, this is Paula. I can
Sure.
someone just wrote, get social worker involved. Yeah, I mean, I guess the first thing I'd probably do is try to the extent I could, acknowledge the suffering, because it's honestly unfathomable, and to thank him for sharing, because we can't help things that we don't know about.
Yeah.
And then, yeah, in terms of fixing it, I would have no idea. but I would start with acknowledgement and take it from there, and definitely get social worker involved. But that's my answer to almost every problem, so I don't know if that counts.
No, that counts. I think acknowledging the pain that he's experienced, and also his bravery, is a great place to start. And it's a really complicated situation, which, this is part of why the Weinberg Center exists, so we can help people like Mr. N come into shelter and meet his rehab goals, while also addressing the abuse that he's experiencing from Tara, someone who he's, loves and cares about and wants to help himself, but also, he needs to take care of himself at this time. He would be in a really dangerous situation if he were to return home.
We're a PACE organization, and David Heisig, and what we do in these situations is we find alternative housing. We put them in one of our respite areas, protected. We have a variety of options, skilled nursing facilities to shared aid buildings and so forth, apartments. And we extract people who are in dangerous situations like this. We get the Adult Protective Services involved right up front to make sure there's documentation. We have a team approach so that everything's documented. We are very careful about looking at who the healthcare proxy is, who a backup healthcare proxy is, what patients' wishes are. In situations where there could be financial abuse, we make sure we have the power of attorney on board, and we kind of comprehensively look at the overall situation. And these are difficult. each one is extremely different.
Yeah,
Difficult. Is Tara only dangerous in the house? Does Tara
right.
have a car and could be dangerous in multiple places? Is Tara only a threat to him or to anybody else? All these things have to be evaluated. Sometimes in the worst case scenarios, we've had police involved when we witnessed or known about an actual threat, assault, or even a battery, and extract folks from them from the potential harm. But these are very challenging, and every single one of them is different. But one of the things that's kind of key to this is if you can't discharge somebody into an unsafe situation, so you really have to plan for a safe situation. And as I said, they can be unique.
David, do you find that your teams are seeing this abuse like when you're onboarding cases and they're being enrolled in the PACE, or are you discovering them later?
It is variable. I would say I don't have data where I can tell you statistics. My gut feeling anecdotally is that it's more when we're onboarding people that we're inheriting a situation that is unstable, and somehow, some way they're kind of being directed in our direction. But there are situations, obviously, where we get caregiver burnout.
Yeah.
And we have somebody who is a loving family member, is very reasonable, but something pushes them over the edge. They are burnt out. And then there's a lashing out. And then the situation has to be dealt with. We've had quite some extremes, but you're absolutely right. It could be both. But I think if I had to guess, looking back over the last few years, it would be probably the predominance are people who are joining our program.
Yeah, I used to work for a PACE in Portland, Oregon, and our experience was that we were referred a lot of really challenging cases, in part because we had this team approach and could handle complex situations. So that's, it's interesting to hear that's happening here in New York too.
Yeah. In fact, when we refer people to APS, they often say, well, gee, you guys are a PACE organization. You should be able to take care of it. And we say, in large part, we can. However, there are legal requirements of making sure APS is involved, from a documentation standpoint and from a tracking standpoint, and sometimes from the requirement to get an actual somebody, a surrogate to cover for them, or a guardian even. So it's a partnership, but PACE organizations often end up being safety nets for this type of situation, if they exist, and they don't obviously exist in many, many places.
Yeah, thank you for sharing that. Anyone else, or should we move to the next slide?
I think let's move on. And we can keep talking as we go. But so Meredith already introduced me. My name is Malya Levin, but I was the attorney who did a lot of the legal work for Mr. N when he came into our shelter program and needed assistance returning home to his longtime apartment safely. And I'm going to show you a couple of slides that we actually got from a geriatrician who we've worked with in the Bay Area. Her name is Dr. Carla Parasinoto. She's really amazing. Many of you may know her, but to me, these illustrations were really like an aha moment, because they really showed what is going on, what we're sort of seeing in real time with so many of our clients, including someone like Mr. N. So you can see here, this is a younger person, and all these different domains are going on simultaneously in their lives. They have their medical needs are sort of one part of what's contributing to their function. But each of the domains is kind of separate. They overlap. But let's say if somebody has a medical setback, familial and social issues aren't necessarily affected by that. Their cognition's not necessarily affected so much. Their environment's not necessarily affected. All these different domains are sort of functioning separately. And for someone like Mr. N, you could see that that was likely the case. He's had this relationship with his daughter, Tara, where she's been abusive, and he's more or less been suffering in silence and dealing with it, we learned, for decades. But he was able to really keep the rest of his life sort of going as it was and sort of segregate the way that he dealt with her from the impact it might have on the rest of his life. But as people get older, they begin to experience, as you know, multiple chronic diseases, and that, coupled with problems in other domains like elder abuse that's not being acknowledged, can really contribute to functional decline in a huge way. And this new Venn diagram is supposed to illustrate how that's the case. So now we have the same Mr. N who has this medical setback where he's had this surgery, and that setback is hugely impacting what's going on in his family, his ability to sort of handle his own life in the way that he always has. And that is really what's prompting this cry for help. But because all these domains overlap, it's really hard without older adults talking to us and telling us what's going on to identify what's contributing to what. Is the person confused because they've had a medical issue, because they don't have an environment that's helping them to live in a healthful, trauma-free way? Is it because of familial or social factors? Like, what is causing what when you're seeing someone? And as they get older, it's harder and harder to determine that. And Mr. N is a really good illustration of that. So I'm going to talk more generally now about some of the risk factors for older adults experiencing abuse. Many of those are illustrated by Mr. N's story that Meredith just told you about. So, and we'll look at them really in terms of the way they impact individuals, their family and social circles, and the larger community and societal environment that they're a part of. So Meredith already talked about a bit about neurological disease, and that the few studies that we have indicate that people who are living with neurological impairments, like some form of dementia, it really experience abuse in staggering numbers, and it really goes largely undetected. And you know, in large part, that can be because even if people who are experiencing dementia are outcrying, are sharing it, so often they may not be believed. And the people who are causing harm may even, use their sort of cognitive privilege to undermine what the person who is experiencing harm is saying. So we all know, once somebody has a diagnosis of dementia, somewhere in their medical record, it really colors the way that people treat what that person says. We actually, unrelated, Meredith and I worked quite extensively on another case where there was an older adult who was experiencing abuse, and the person causing her harm was also her daughter. Her daughter was in fact a medical doctor, and the daughter really fabricated a diagnosis of dementia about this older adult, knew all the symptoms, knew the medical terminology, knew how to describe it, and managed to convince a bunch of people that this older person couldn't be believed about what her daughter was in fact doing to her in her home because the older adult had dementia. And actually, it took medical providers in a hospital observing this older adult over time to say, we're not seeing any signs of dementia. Like, the way that this daughter's describing her mom is actually not at all true to the way that she's in fact presenting. And that's when they really started talking to the older adult more, and the whole story came out, and some of the story came out, and she was referred to our program. So it's a huge risk factor for abuse, the diagnosis and the disease itself. Previous trauma, I mean, we see this with Mr. N. He's had to deal with his older adult, mentally ill child for decades, really addressing her needs on his own in silence. There were a lot of cultural factors in this case where, as a father, he was really expected to sort of just take care of his daughter no matter what the cost, kind of, keep her safe. And he really took that on as a requirement of himself and a big part of his identity. And a lot of the work that we did with him was trying to convince him that it was okay now to put himself first. Because even though he had that moment in the hospital where he said, I can't go home, I'm a porcelain doll, he vacillated so much over time while he was with us about what he should do, especially legally, as we came to the realization that really what we needed to do was to get an order of protection that would in fact remove his daughter from his apartment, which would make her at least temporarily homeless, which was really what he saw as his number one role as a father to avoid. And so he was extremely torn about this really putting his own well-being before his daughter's. And I'll talk a little more about that. But previous trauma is a risk factor for elder abuse as people get older. Functional impairment, poor physical health, obviously that makes people more dependent on caregivers, and more vulnerable to abuse of various kinds that might be caused by those caregivers or by others. Self-neglect, people who are not caring for themselves are more likely to be taken advantage of because their finances may be in disarray. They may be isolated because of their self-neglect from other protective social family and community supports. And so they're more vulnerable. Isolation really, and I'll talk more about this in the next slide, is the biggest risk factor for abuse. Because there's no one to see. There's no one to see that it's happening. And we'll talk a little more about how that's sort of reinforced on a community level in a minute. But mental illness as well, in a way, I think, anecdotally, sort of similar to neurological disease, people who have mental illness are often stigmatized. They may be isolated from other family members or protective social supports who might assist them. And also often people who have a mental illness diagnosis are not believed when they talk about the abuse that they've experienced. And so that abuse can go unchecked and unaddressed. When we think about the people who are in relationship with these older adults who may be causing them harm, a shared living arrangement can often be a risk factor. We see a lot in New York City. It's very interesting and sort of unique situation here where older adults, even older adults who are low income, who have no assets, who have very low income, can have these sort of priceless housing situations where they have a 3-bedroom apartment on the river in Manhattan, and it's like $300 a month because they've been living in it for 50 years. And maybe those 3 bedrooms used to be full of family members, but now they're empty. And it's so easy for a family member or even a new friend to sort of ingratiate themselves with the older adult, move in under the guise of being helpful and helping the older person maintain their independence. And then before you know it, that person has moved in other people. There's all this activity back and forth in the apartment. There may be illegal activities going on in the apartment. And the landlord catches wind of this and can begin an eviction proceeding against the older adult because they're the tenant, even though they're actually the victim of what's been going on, but they're so isolated. And the landlord is very motivated to get back this apartment, which is, way below the market rate that they can get once they gut renovate the place. So we see that very frequently with our clients. Like Meredith said, most commonly, these are people who are older adults' families, often adult children, their spouse, and very often it's a caregiving relationship. That's sort of a hallmark is abusing the trust that comes with that vulnerability of needing care. And I'll say also, often the caregiving relationship is reciprocal. I mean, when you see a patient, it might be most obvious that, they're the ones receiving the care because they're older. And the younger person who's their adult child might be helping them with activities of daily living, might be doing some kind of custodial, assistance, keeping track of them, reminding them of things. But very often, especially if it's a long-standing relationship, the parent or the older adult is also caregiving for the adult child. The adult child, the person who's causing harm, might be financially dependent on the older adult, might be dependent for companionship, for assistance in moving through the world in a way that that's always been the dynamic. But now, as the older adult has gotten more vulnerable in other ways, the abusive element has really, risen to more of a fever pitch. And sadly, our society is quite ageist, and the community and societal supports that might be there in a less ageist society to check some of these individual factors just aren't there. And if anything, they help to perpetuate the individual factors. So older adults are extremely isolated, and everyone sort of accepts that level of isolation as kind of par for the course. I think older adults, it's accepted that older adults are home alone for extended periods, don't have social connections. stay home, you know, even though they have fixed patterns where they're going to the same places every day or every week. If they're suddenly not there, people are like, oh, they must not have been feeling well. There isn't the same level of concern if, let's say, a younger person suddenly doesn't show up in the places that they're supposed to. Social supports are disappearing as people get older. You know, their relationships, people may be dying, may move away. Um, and just in general, ageism, sort of the expectation that older adults' quality of life is going to worsen as they get older and they're, you know, going to die. And that's kind of an expectation that society has for sort of the trajectory of people's years as they get older. And that really can color hugely the experience of an adult who is experiencing harm. This map here that I'm showing you on this slide was actually prepared in the wake of Hurricane Sandy to think about evacuations that might be needed in other potential mass casualty events where people need to be evacuated. But it shows the percentage of people living alone in New York City who are 65 and older, and you can see it's a lot of people. You know, it's an aging city, and these people are living alone. So if you think about, you know, what that means in terms of who's checking in on them, who might see that they are experiencing some kind of abuse, that something has changed about their status or their you know, their stability. It's really it's quite significant. And I'm going to talk just a little bit more about the impact of elder abuse. And a lot of these you know, a lot of these things are also risk factors. So the irony is that the same things that put people at additional risk for abuse are also exacerbated by the abuse itself. And so the circle continues and it's sort of self-perpetuating. But we see that when people experience abuse, their functionality declines. They are less able to function independently. They're at increased risk of nursing home placement. They're at increased risk of death, actually. There's been a lot of studies that nursing homes, emergency rooms see people who are victims of elder abuse, you know, even accounting for other comorbidities at exponentially larger rates. In terms of physical health, you're often seeing malnutrition, dehydration, a lack of medical care. Our Mr. N, for example, we know at the height of COVID, when there were all those shelter-in-place orders, he was walking the streets in violation of those orders on his own just to get away from his daughter and get relief from the sort of constant threats that were the result really of her and her illness and being in such close proximity with her with nobody else around. So that level of physical risk that may or may not have played a role in, you know, the other health, the more acute health issues that he presented with and the degree to which they had gone undetected. But we often see clients who present with these, you know, issues like malnutrition, dehydration, but who also haven't been to the doctor in years or even a decade because they've been trying to hide what's going on. The person who's causing them harm has been trying to hide what's going on. And as a result, you know, all kinds of chronic conditions can become exacerbated and more acute. Also, psychological health, we see more anxiety, more depression. I think that that's sort of obvious. But again, I think ageism sort of, we kind of expect older people to be anxious and depressed in our society. And it's seen as normal in a way, you know, as medical professionals, you may not see it as normal, but I think the layperson does see it as normal. And I think a higher level of it is tolerated among older adults. So it's much harder to see it as the impact of abuse. And cognitive health, people's cognition can really decline in a very noticeable way. And we've seen this so often with clients who may first come into our program and have to be placed on a memory care unit. And then just with the stability that comes with living somewhere safe, getting regular nutrition, getting supportive counseling, knowing that their needs are being addressed, that the abuse they've experienced is addressed, they wind up moving to another floor. You know, they don't need that level of care anymore. Their whole sort of presentation completely changes. And it's really because the abuse is what had that effect. Meredith, are you?
Yes, this is me. So
Great.
as a physician, these are some red flags that you should be on the lookout for. there can be a lot of different reasons for these issues, but you should have abuse on your differential. So probably the number one thing to be on the lookout for is isolation, and I have it at the bottom of the slide, but it should probably be the first. And that's especially the case when a family member is isolating the older adult. So maybe the older adult would be not coming to your office as frequently, but turns up like in a kind of like a medical crisis. If the older adult is talking about recently losing their financial independence, and this is, not the norm for them, maybe they're talking about facing an eviction proceeding, or not being able to afford something that they've always been able to afford before, that should be in a red flag for abuse. Late last year, we admitted a man who confided to his infectious disease doctor that he wasn't able to afford new reading glasses. The doctor had handed him something to read, and this man was like, "Oh, I can't read it." And the doctor said, "Well, where are your reading glasses?" He's like, I can't afford new ones." And this was not this man's norm. He was meticulous about his healthcare and his finances, and this was a red flag. And the doctor asked, "What's going on? Why can't you afford this?" And that led to this disclosure of how this older adult was being mistreated by his partner. And eventually he came into shelter with us and is doing a lot better. But so this recent loss of financial independence, when this wasn't the person's history, is a big red flag for abuse. Executing new advanced directives like a healthcare proxy and power of attorney, these are great tools to prevent abuse, but they're also the tools that are used to perpetuate abuse. And so if you come across an older adult who has met a new friend who is trying to act as their advocate, and the older adult is talking about executing new directives, that's a big red flag that there's possible abuse. Also very suspicious suddenly when this new friend is moving in to the older adult's home and acting as a caregiver. That's also a red flag that something is going on there. Malya gave this example of a previous client where her daughter was, diagnosing her with dementia. And that's also a big red flag when another party is trying to control the older adult and describing them as not having the ability or the capacity to make decisions, and is speaking for the older adults or telling you don't listen to them, she has dementia. That's a big red flag that the dynamic is not safe, and that a person is trying to control the older adult. And really what you want to do there is try to speak with the older adult alone and ask more questions and see what's going on. Missing assistive devices, that can be because the person who's being harmful is trying to prevent the older adult from addressing the abuse, or maybe because the person is overwhelmed and neglecting the older adult, or it can be a red flag that the older adult isn't able to replace items, like it was in the case of the gentleman who couldn't replace his reading glasses because he was being financially exploited. And then weight loss and dehydration can certainly be signs of serious neglect, like Malya was talking about in the previous slide. Also changes in routines and withdrawing from activities. We spoke a little bit about these like ageist beliefs that older adults are depressed and anxious, but we also don't question when an older adult kind of like disappears from their routines. Like if someone was always going to the senior center or always going to church and suddenly they're not, we as a society, we kind of expect older adults to fade away and not be as engaged in their routines in life. And of course, an older adult can become sick and may not be able to participate in their routine, but it can also be because they're being prevented and being isolated in order to disguise the mistreatment that's happening in the home. Next slide. So we like to talk about the bruising studies that have been done, because they really reveal, some of the hidden factors of abuse and some of the themes that that you can see as a physician. So older adults who've experienced abuse, physical abuse, the bruises that they have tend to be larger than 5 centimeters, and they tend to be found on the older adult's face, their right arm, or their posterior torso. That's as opposed to someone who wakes up in the middle of the night and accidentally like walks into the wall or accidentally gets a bruise and, they're not sure how that happened. If an older adult is experiencing abuse, there's a high likelihood, 72% actually, will have some form of bruise on them. So if an older adult has a bruise, you should be asking about it and how they got the bruise, because the majority of them, about 90%, are also going to be able to tell you the cause of the bruise if it was caused by a person harming them. Much less likely if it was an accident. Just like us, if we wake up in the middle of the night or we accidentally bang our hand against our desk, like we might not remember that down the line. But if it's been inflicted by someone else, the chances are the older adult is going to remember that happened. And that's also regardless of a dementia diagnosis. Those kind of like emotionally charged events, the older adult tends to recall. Next slide.
How much more time do we have? Can I just ask?
10 minutes, I think.
10 minutes,
Okay.
yep.
10
Great.
minutes.
So this is our what we call WC RAPS, which is our Weinberg Center risk and prevention screening tool. And this is a statistically validated screening tool that we developed for both risk and incidence of elder abuse. We believe strongly that in a medical setting, the same way older adults are screened for depression, for high blood pressure, they should be being screened for abuse. And in fact, part of what we do at the Hebrew Home at Riverdale, apart from the sort of wraparound intensive services that we provide to the people who come into our shelter program, is every new patient who comes in for either long-term care or more frequently short-term rehabilitation following a hospitalization is screened for risk and incidence of abuse. And wherever there's a positive screen, which is a positive answer to any of these questions, a member of our Weinberg Center team is following up with that person to further understand what the nature of this abuse or this risk is, and to offer them support. And that support can be really wide ranging, and it really depends. I think, as one of the participants said earlier, each of these cases is so different. And also each client and patient's needs and wants are so different. And that's really what we want to be responsive to. So we offer anything from, referrals to community-based legal agencies to, assistance, direct legal assistance, to staying in our shelter program once their rehab days are complete, if it turns out that really their home or the place they're returning to is unsafe due to abuse. But we feel that not only is this something that needs to be screened for, but also that when an older adult has experienced a hospitalization or some kind of acute health event, that's the really sort of a perfect window to be asking and finding out about abuse, because they're away from their home environment. They've experienced a setback or some kind of event where they're likely more aware of their physical frailty than ever. And it's it can really be an inflection point where they can be evaluating, what's going on in their lives and accepting services or help that's being offered to them. So these are the questions that we ask. I think that we may have already shared this screen in the materials that we distributed, but if not, we're happy to provide it and to talk more about it. But we've found that the levels on which we detect abuse through this screen are really on par with the general 1 in 10 statistic that we see in the community when the screening program is operating optimally. I'll say, like anything, screening, first of all, it's not an easy undertaking. It has to be something that's done in a trauma-informed way. It can't just be sort of one more piece of paper among many that's part of an intensive intake, which so many of these screens can be. And of course, that really cuts down on its efficacy. And we've really tried to make it as its own standalone intentional process. Meredith's really the expert in this area, but it's something that's we've seen is really a process is really important. But also knowing how to respond once someone screens positive is really important, because I think, if you implement some kind of screening process, or you say, okay, I'm going to start asking more questions about this to my patients or in my practice, if you don't really know what you're going to do if someone discloses to you, you're not going to be asking in a way that is open to or invites disclosure, because you're nervous about the possibility of a positive disclosure and what that's going to do. So we really believe that elder abuse is a complex problem that I hope we've illustrated through this presentation impacts a variety of areas and needs to be addressed by a variety of different professionals. That's why we take this multidisciplinary approach within our team itself to address these issues. We already talked about adult protective services. They're so often kind of the frontline sort of community responder when, especially in a medical setting, when there's sort of a problem that's been detected, but there isn't really the resource to fully address it or fully sort of explore it. We want to call people's attention to Weill Cornell's vulnerable elder protection team. That's a special, many of you may know about this, but it's a special emergency room based program they have to address elder abuse, really to address it, I think, medically first and foremost. People come in to the emergency room, they get sort of a full medical assessment, and then there's also specialized social workers who are working to look at them, look at the abuse that they've experienced from a medical, but also from a clinical perspective, and work on figuring out how to address it. Because so often a hospital can kind of become this default place where people experiencing elder abuse can sort of end up as a last resort when their home becomes unsafe. But then, the hospital is really not the right place to be addressing sort of these long-standing abuse-related issues when there isn't sort of an acute medical component involved. So I think the Weill Cornell program is really intended to address that. And we also just want to say that we're here, and we're happy to speak with anyone who may have an abuse case or suspicion of abuse. We have this, we take referrals directly to our shelter program, but we also have a consultation line where we're happy to just talk through cases of abuse that you may be seeing or think that you're seeing. If you wanted to talk through what other potential responses are, directing your attention also to, we worked with the New York State court system to develop an elder justice resource guide that's really geared toward legal professionals and talks a lot about the way that the court system can be more friendly to older adult litigants. But it also has elder abuse response resources in every county in the state. That is, the resource portion of it is quite robust. And so I would direct you there also, especially if you're outside the New York City area, to just get a sense of who your local multidisciplinary community-based elder justice agencies are, who the players are, so that you, if you're inviting disclosure, it's really with a knowledgeable with a knowledge base that can allow you to respond in a robust and meaningful way. And we're always here and happy to help you do that. And this is our team. You see me and Meredith, our director, a couple other of our colleagues. And we're really happy to have been with you and to have shared this sort of intro to what we do. And thanks so much for having us.
Thank you so much. That was great. So if anyone wants to, the CME link is there, and I see Dan raised his virtual hand. Go ahead, Dan.
I just really wanted to thank you so much. This is a really eye-opening presentation and couldn't be more timely. One of the things I'm less happy about having to do is I sit in on our interdisciplinary discharge planning rounds with our residents each morning. And we have a case right now that I really don't know what to do with, and I'm going to call the consult line. I'm going to have someone call the consult line tomorrow because it can't go into it here. But you will be getting a call from New Rochelle tomorrow. Thank you very much.
Great. Great. Looking forward.
Yeah, and I think actually the whole presentation was eye-opening, and I've heard a different version of this, and I still learned so much today. So I look forward to March when we're going to learn even more. I think you raise a very good point. I think we are, even those of us that are like worried about something and care about it, are like really afraid to like open up that Pandora's box, because then you're like, okay, great. Like, now what? You know, it's like when you ask someone, you know, how their day is going, and you assume they're just going to be like fine, and then they just start like crying because like the whole world is falling apart, and you're like, all right, I guess I'm glad that I asked, because I do want to help you, but like, how am I supposed to help you? So this was so very practical. Thank you. I do have a question for you, and I don't know how often it comes up, but like, what happens if you do everything you're quote supposed to do, and like, let's say the gentleman that you spoke about, like what happens if someone just decide to go back to the abusive environment? Like my husband's a geriatric psychiatrist, and you know, he says like people are allowed to make bad decisions, like as long as they have capacity and they know the risks and benefits, like you can make bad decisions, but like, you know, opening the door for them to go back to a dangerous environment just seems different.
Well, it's really funny you should say that, because that's pretty much exactly what happened in Mr. N's case. In fact, Meredith and I discussed that we were going to kind of give this follow up, and then I completely forgot to do it. But basically, yes, so I represented Mr. N as his attorney to get an exclusionary order of protection to get his daughter out of his home. He, like I said, was extremely ambivalent. He was also getting, he had that one supportive daughter that Meredith mentioned. He also had a lot of family who were quite angry at him that he would consider kicking his daughter out. And in fact, we had this very dramatic moment where he was supposed to testify in the hearing about his daughter being excluded. And he literally came in and he was like, I can't do it. And he had just gotten off the phone with a son, or I forget who it was, but someone who was like, how dare you do this and kick her out of your home. And I had to literally ask the court for a minute and have this sort of we all came in, we were like giving him this pep talk, and he was like, okay, I'll do it. And he testified. He did wonderfully. He was very credible and persuasive. We prevailed. We got the exclusionary order. His daughter left. She was staying with family, so I don't think that I don't think she went to a homeless shelter, at least not immediately, but he wanted to go home as soon as possible. And so we discharged him, and we referred him to a community legal agency to continue with the case to get the final order. And I'm fairly sure that he wound up inviting his daughter to come back in and didn't end up getting the final order of protection. I don't know. And I don't know what has happened to him after that. And I think it's a super frustrating element of our work that if somebody is cognitively impaired and is no longer able to make their own decisions, then that's sort of a different question. But if you have someone who you don't have questions about their cognition, you need to be responsive to their wants. Like you said, they have the right to make bad decisions the same way that he was making the same decision that he had made 20 years ago, and no one questioned it then. But it's really hard when you've worked so hard and you know what you want the person to do for their own safety, but you can't make them do it. And we experience that all the time. Meredith, I don't know if you want to add anything.
Yeah, I mean, sometimes it's like almost taking a harm reduction approach. Like maybe it's helping the person execute a new healthcare proxy, or locking down their bank accounts, or giving them resources. You know, it's so hard because, like Malya says, you want to fix the situation and you can see the path, but maybe they're just not ready to do that. But you can kind of show them what the next steps would be when they are ready.
Right. And you provided not just the path, but like a person, like a resource, like the concept, like there is an alternative and there are people that can help me. And I don't remember the data, but I know that people like domestic, younger domestic violence, they don't leave generally after the first event. Like it takes multiple attempts to kind of break that cycle of, this is
I think it's
God.
7 times. I think it's 7
Yeah.
times. Yeah. Right.
Well, you guys do amazing work. Thank you so much for sharing your experiences and your expertise with us. Again, everyone save the date, and now I forgot already, March 19th, Tuesday at 4:00. And make sure to claim your CME for this course, and you have to answer some questions on the, to get your CME. Is there any other comments? I wasn't sure if I saw something. Okay. Well, again, thank you tremendously, and for the work that you do and for sharing with us. We've all been inspired. We're going to be more aware and not be afraid to find out and then do what we can.
you.